Hello my dear curious and studious students of surgery. Myself Dr. Mahesh Chaudhary. I am warm welcoming you in my surgery lecture series. This surgery lecture series contains entire surgery with anesthesia, with radiology, with orthopedic. So stay tuned with us. Let's start our surgery lecture series. Welcome dear students in my surgery lecture number 40, that is the tumors of the anal canal. In this lecture we will cover the benign lesions like Condyloma, Acuminata or Warts, malignant lesions like Epidermoid carcinoma, Basal cell carcinoma, malignant melanoma of the anal canal and lower gastrointestinal tract bleeding and its management. Now first we start with the benign lesions, that is the Condyloma, Acuminata or Warts are the only benign lesions seen around the anus. The anus and the perianal regions are affected. These are caused by the fiterable virus and the infectious organisms. The extent of the disease varies to a few small warts to an extensive mass occluding the anal canal. Bleeding, itching and pruritus any are common symptoms. Are examinations, soft papillary appearances becomes obvious without any induration. Multiple biopsies and histological examination, these are the papillomata with central core of the connective tissues covered with the epithelium should be done to exclude the associated squamous cell carcinoma. Now the treatment, small warts can be destroyed by 25% podophyllin solution and bicloracetic acid. Extensive warts in the perianal region or in the anal canal requires excision. Close follow-up is necessary as recurrence rate is about 60%. Immunotherapy using autogenious wart tissue vaccine may be used in conjunction with excision to reduce the recurrent rate. Dear students, you can watch the image of the Condyloma acuminata of the anal canal is seen on your screen. This is the typical picture of the Condyloma acuminata. This is the another picture of the multiple Condyloma acuminata and warts around the anus on the buttock. This is the another picture of the Condyloma acuminata. Now the malignant lesions of the anal canal. Mainly three types of the malignant neoplasms are seen at the anus. One, squamous cell carcinoma, which is the commonest. Second is the basal cell carcinoma, which is the next common, and third is the melanoma, which is the least common. Now the epidermoid carcinoma. This includes two varieties: squamous cell carcinoma arising below the dentate line and transitional cell carcinoma arising from the transitional zone above the dentate line. Ulcerative variety is mostly seen as indurated ulcer or ulcerated nodules. Rectal bleeding is the main symptoms along with pruritus any. Early diagnosis can be made by the careful examination and biopsy. One must exclude carcinoma of the rectum and colon. Now the treatment. First, local excision. This is reserved for small and well differentiated tumors which have not invaded the muscular layers. A wide margins of at least 2.5 cm of the normal tissue all around us should be excised with the tumors. Close follow-up is performed to exclude recurrence and to detect secondaries in the inguinal nodes and will require block dissection with removal of glands. Now the radiotherapy, intestinal radiation with gold radon seed may be suitable for small lesions. Now second is the basal cell carcinoma. This tumor usually starts near the dentate line. This is the relatively low malignant than the epidermoid carcinoma. Lymph nodes are usually not involved. Treatment is the small tumors may be given irradiation therapy, but large tumors requires excision in the form of the abdominoperineal resection. Now next condition is the malignant melanoma. Melanoma of the anal canal represents the third most common site of the melanomas, preceded only by the skin and eyes. Almost all the tumors arise from the epidermoid lining of the anal canal adjacent to the dentate line. Anal canal melanomas spread submucously into the rectum. Now the treatment. Radical excision is the treatment of choice in malignant melanoma. Abdominoperineal resection is the operation to be performed. Malignant melanoma is radio-resistant and does not respond well to the chemotherapy and immunotherapy. Prognosis is poor. 5-year survival rate is not more than 15% in the best institutions also. Now here is a picture of the malignant melanoma. Typical picture of the malignant melanoma is seen on your screen. This is the another picture of the malignant melanoma. Now the next point of this lecture is the lower gastrointestinal tract bleeding. When the source of the bleeding lies below the duodenojunction flexure, it is referred to as the lower gastrointestinal tract bleeding. The bleeding may be fresh, altered or occult. Lower GI tract bleeding can be divided into three groups. One is the patients with minor bleeding, that is the occult, and second is the patient with slow bleeding, that is the moderate, and C, the patient with rapid bleeding, that is the severe. Now the first occult blood is that which is detected by routine chemical test of the stool with or without systemic evidence of chronic blood loss. About 10 ml blood loss per day is necessary to have stool occult blood test positive. Second is the slow bleeding. Is manifested by recognizable blood loss either altered or fresh per annum in a stable patient. This patient may become anemic with or without systemic changes. Now C, rapid or severe bleeding is defined as a rapid blood loss per annum which is reflected by hemodynamic instability if left uncorrected. The loss of blood requires 2 units or more of blood for transfusion to bring about hemodynamic stability. Now the causes, first is the local causes, anal causes, hemorrhoids, anal fissure, mucosal prolapse, ulceration, that is the Crohn's disease, carcinoma and fistula in ano. Second is the perianal prolapse rectum and piles, ruptured perianal hematoma, ruptured anorectal abscess, injury, condylomata, carcinoma and skin excoriation. Third is the colorectal diverticular disease, very common in western countries, though it is the quite rare in this country. Various types of the polyps, villous adenoma, carcinoma, ulcerative colitis, angiodysplasia, inflammatory bowel disease, endometriosis, Crohn's disease and hemangioma. Now the small intestine, reasons from the small intestines are intersusception, Crohn's disease, mecal diverticulum and the tumors. And general causes are blood dyscrasis, as we discussed in the upper GI tract bleeding, and the next is the drugs. We have already discussed in the upper GI tract bleeding, then liver failure and the renal failure. Now the clinical examinations, amount of bleeding, the color of the blood loss, this inquiry must be made regarding the amount of the bleeding and the color of the blood test. Bright red coming from the rectum color or anal canal. Dark red coming from the ascending transverse and descending or sigmoid colon. Black color, if there is a black color, that is the malignant from the small intestine and higher up. Relation of bleeding is defecation must be inquired whether during or independent of the act. Now the bleeding occurs at the time of passing her stool, there may be the acute fissure in ano. A streak of fresh blood on the side of the stool in the both acute and chronic fissure. Just after defecation, the blood occurs and the blood is bright red and scattered all over the pan, that is the internal piles, that may be the internal piles. When child comes with bleeding per annum, that may be the rectal polyp. Blood is alone or blood with mucus, then it should also be inquired regarding another conditions to exclude the another conditions. Blood alone in polyps, villus, adenoma and diverticular diseases. If blood is alone, then there may be the chances of the polyps, villus adenoma and diverticular disease. Blood with mucus in ulcerative colitis, Crohn's disease and intersubscription, etc. All these conditions are a blood bleeding with the mucus discharge. Now the pain, very much associated with the fissure in ano, pain absent in hemorrhoids from carcinomatous condition and polyps. Pain is absent in hemorrhoids, carcinomatous condition and the polyps. And inquiry should be made regarding abnormalities of the bowel habit. Now the local examination, abdominal examination may reveal a lump in case of carcinoma and intersusception in the per abdomen examination. In case of intersusception, there may be emptiness of the right iliac fossa, which is common as sign de dance. In ulcerative colitis, distension of the abdomen, so carefully per abdomen examination is necessary to find out the cause of the bleeding per annum. Now the rectal examination is highly important. All anal, perianal and majority of the rectal condition can be diagnosed through this examination. Now the investigation, which investigation is to be done in this lower gastric bleeding condition? First is the endoscopy, proctoscopy, sigmoidoscopy and ultimately colonoscopy are of immense value to diagnose the cause of the lower GI tract bleeding. Accurate localization of lesion is possible in about 95% of causes with endoscopy. Another method of colonoscopy called vital colonoscopy includes CT and EMR colography, seems promising to detect the earlier cancer. There are several methods to stop bleeding through colonoscopy, that is the electrocautery, laser ablation, injection of therapy, hemoclip, argon beam, etc. Next investigation is the radiological examination. No scope for colonoscopy, barium minima examination is very helpful. Double contrast technique of barium minima is greatly increased in diagnostic accuracy. Where there is not much scope for colonoscopy and barium minima, then this radiological examination is very immense. Now The next investigation is the nuclear scintigraphy. Technetium-99 radio-labeled red blood cells scanning as a high diagnostic value. The long intravascular half-life of the labeled red cells allows repeat scanning and increases the probability of the isolating those lesions of bleed intermittently. Technetium-99 radio-labeled sulfur colloid does not localize the intact exact bleeding site, but can detect active bleeding as low as 0.1 to 0.5 ml per minute. This is a very fine nuclear scintigraphy. Advantages: accuracy, safety, its non-invasive character, freedom from the contrast relation problems, and its low cost. Next investigation in the low tract GI bleeding is the angiography. As mentioned in the upper GI tract bleeding, the success rate of the selective visceral studies is high when the blood loss is at the minimum rate of the 0.5 ml per minute. Selective angiography is necessary through superior mesenteric or inferior mesenteric artery. Hemorrhage can also be controlled by selective infusion or of vasopressin or by deliberate injections of the embolic material. Now the management. This includes general management and local management. General management includes the measurement to resuscitate the patient from shock and at the same time to give blood transfusion to replenish the blood loss, and local management depends on the cause of bleeding. They have been discussed earlier. Only angiodysplasia have not been discussed earlier. Dear students, you can watch the YouTube videos regarding these points, and here is the end of our surgery lecture number 40, that is the tumors of the anal canal. Thank you.